Thank you, everyone. Enjoy the dinner. I'm sorry for the ones who saw this the other day. I also presented this at the ISC, but I guess hopefully it will not be too boring to hear it twice. This is, I'm presenting on behalf of many, many people that you can see here and on behalf of the whole executive committee and all the authors that have been working on this project for the last 2 years. This is my disclosures and nothing to disclose except for the fact that I'm still the vice chair for a few more months, and it's been a really good journey. And I'm very happy that you guys gave me the opportunity to serve to this important mission. I don't think I need to tell the audience here that mechanical thrombectomy has an efficacy that is a match in many fields of medicine, and it has shown enormous benefit for patients when treated within the first 24 hours. Unfortunately, and this is the reason why we are all here, there is a lot of limited availability of this tremendous therapy. And in 2018, it was calculated that only 84% of the population received this therapy when they were presenting with LVOs. The great job for many of you here actually demonstrated that those numbers needed to be updated. And this disparity in mechanical thrombectomy treatment was primarily driven by the the GPD in each individual country, and countries with the lowest GPD and the less resources actually pay a substantial amount of burden of stroke without the ability to help those patients with LVO, with rates below 1% in the low income countries and actually less than 3% in the middle income countries. We also try to understand what were the significant barriers to access this before we got into the journey of building the scale. And we kind of came up with all the available literature to try to identify potential barriers in developing as well as in developed countries and categorize those barriers in three main categories. The diagnostic category, where basically LVO detection capabilities are jeopardized. The physical access category, where mechanical thrombectomy treatment cannot be performed because of lack of proceduralists, lack of expertise, or inability to have enough trained people. And the financial access, which is also a reality in many countries, where the insurance doesn't cover the procedure or the devices are not available for the majority of the population. With that objective and keeping that in mind, we came into this project with the aim of creating a global MT access score using a systematic mixed methodology that I'm going to talk about in a minute. And the hope or the aim was to really measure the drivers of access and provide a roadmap that helps to quantify those barriers and being able to implement public health interventions to accelerate treatment of mechanical thrombectomy worldwide to the patients that need it. For this, we follow first a routine methodology of doing a systematic review for investigators review or screen all the abstracts first, and then really got the key papers in which at least one attribute or one element that describe a barrier was really incorporated into the paper. And each individual investigator extracted those attributes and categorized those in the different three categories that I mentioned before. Once those attributes were obtained, then Delphi methodology was incorporating following the UCLA consensus methodology. Then we selected a panelist of experts with different backgrounds and also different geographic locations in order to really evaluate those attributes and kind of get their expertise to create a scale with the main attributes as well as the weight in each attribute, depending on what they think it was important. At the end, a scale was created, and then after the initial scale was created, then there was a second meeting in which correlations between those parameters as well as barriers that probably had presented in the different categories kind of were discussed, and some of them were refined to with objective, reproducible definitions to be able to apply in each specific region. The results are here. A total of nearly 3,000 abstracts were reviewed. From those, 523 articles were read, and then initial review obtained 34 attributes, from which only 26 were given to the panel after the review of the 4 investigators. Then concomitantly, while we were doing the systematic review, invitations to the experts were sent. 5 kindly accepted the invitation. Some of them are here with us, and I really appreciate your willingness to work with us in this project. And they then had the first round, as I mentioned, to really evaluate those, categorize the important ones, naming or giving them a number based on the importance, based on their expertise in their geographical location and field of expertise. And then after that, a second meeting occurred where these, in addition to be weighted, they were also carefully evaluated and better defined to make sure that we could apply a scale that can be reproducible and people understand in each specific region. And this is the final score. I'm not going to go to all the details, but the main attributes that that form or represents the score are public education, that can go from none to very good local and regional and national campaigns, EMS utilization, primarily using EMS to transport the patients on their own in the different percentages that was decided by the panelists. Also, the use of pre-hospital LVO scales in the triage of these patients, availability for transportation, including inter-hospital transport systems to kind of bring these patients from primary stroke centers to thrombectomy-capable centers, as well as stroke protocols incorporated with including a stroke alert, the ability to perform a CTA as part of the protocol when there was a clinical suspicion for patient with LVO, the ability to have telestroke equivalent networks when there was absence of a stroke or a stroke equivalent expert in the hospital, also ability to have 24/7 coverage with a neurologist or ED physician with a stroke expertise, enough amount of MT operators, this was based on the empty glass numbers that we obtained in the paper, access to thrombectomy centers in the region, which basically means that they were able to incorporate strategically located thrombectomy-capable centers, including in rural areas, and availability of devices and biplanes, and finally, government coverage for a specific percentage of population. And these are the final attributes of the scale, and hopefully we'll start to apply this very soon. A few final words about potential limitations. We have to keep in mind that the majority of the attributes were extracted from literature that was mainly written in upper income countries. Therefore, I think we're going to need to really refine the attributes when we apply this in a specific locations. We'll need a prospective validation as we start to apply in different regions, and hopefully evaluate the impact that these public health interventions might have in the different regions after we have the initial assessment with the MTA score. And again, thank you, everyone. Of course, Dilip trusted me 2 years ago with this when there were many qualified candidates to run this ambitious project with zero expertise on this topic at that time. And I really appreciate the opportunity. We are now having the paper under review in a high impact journal. We'll see what the results are. Obviously, all the core executive committee who has really been part of the journey and giving us good advice, our global advisors that are always available, and the 5 panelists that really kind of provide us with expertise within the 2 meetings to create the scale. Thank you so much for the opportunity.
And next, we'll have a presentation by Dr. Sheila Martins on partnering with WHO and other global organizations for acute stroke treatment access.